everybody, can you hear me? Can someone answer?
Yes, we can hear you.
Okay, great. So welcome to today's Cardiovascular MR Journal Club webinar, and welcome from this time from Montreal. In most parts of the world, it's already spring, not quite yet here, but we're getting above the freezing point since 1 or 2 days, so it's getting better. Today's topic will be about T1 mapping and especially in the role of T1 mapping and a little bit of T2 mapping in acute myocardial injury caused by, in this case, in the first case, by rejection of the body to a cardiac allograft, and in the second to cardiotoxic therapy. And I have a question before I ask, is Mohammed around? Because we asked Mohammed to join, but Mohammed is in Australia, so I think it should be around 2 o'clock in the morning, so he may not be able to join. So just in case you are joining, then just give me a hand. I have one Mohammed here, but on the participant list, but I'm not sure it's the right one because the second name I think sounds a little bit different. So there's a paper published in JACC Imaging, and it's by a group from let's say several centers: Australia, Frankfurt, London. And the background of this study is fairly easy to explain. The follow-up of patients after heart transplant is very important to guide therapy, to identify especially two major threats of these patients. One is an acute or chronic rejection response, and another one is vascular disease, allograft vascular disease. They are both distinct from each other, but both are threatening, life-threatening to the patients. And in order to identify a rejection and to respond to it properly early by immunosuppressive therapy, which only should be, of course, given when there's a good reason for that, the gold standard, or currently the clinical standard, is endomyocardial biopsy. So these patients have to come to biopsies all the time. So initially that's within a few months, and later on this interval can be increased. But of course, this is an invasive procedure. It's very inconvenient, has its risk. So cardiac MR as the gold standard method for looking at myocardial tissue characteristics, of course, has been assessed since quite a while. And I think it was already more than 15 years ago that Marie et al. Published a paper on the use of T2-weighted imaging to identify cardiac allograft rejection. That has not really picked up yet. I think that has, to a lesser extent, to do with issues with the methodology or with the basic approach, but more political, because the transplant societies, they are not necessarily all that much into the imaging, and it's just tradition that biopsy has been used there. But of course, that has been challenged, especially recently, by the introduction of T2 mapping and T1 mapping. And this multi-center group here basically aimed to assess the clinical utility of native T1 mapping in monitoring these patients, and they did that so prospectively and had some histological validation. So that makes it a very important paper. So what did they do? So they enrolled all patients undergoing heart transplant at a center in Sydney. And so they were not selected, they were consecutive patients. And they had then basically CMR added to their regular follow-up. So that was the routine cardiac biopsies. And as you can see here, at 6, 8, 10, 12, 20, 24, 32, and 52 weeks after transplant, because that's the time for the most severe early rejection, and added a CMR scan to all of that. If they had a rejection, then as determined by histology, then they repeated the CMR together with a repeat biopsy. Then they used non-transplant patients without any background and a low pretest probability. So these are technically not totally healthy participants, but as healthy as we can get them without asking the neighboring soccer club. And they used a fairly standard CMR acquisition protocol, including an SSFB-based MOLI. That has, and this is important, may have a little bit of a T2 sensitivity that may play a role, but it has to be considered. So they divided the patients into 3 groups. There is this classification by the International Society of Heart and Lung Transplantation, grade 0, no rejection, 1R, 2R, 3R. So that's the severity of rejection. What they did is they identified 3 groups. One was group 0, so that's basically grade 0. One was group 1, that was this ISHLT grade 1. And then grade 2, where they basically lumped 2R, 3R, then an acute reaction, and clinically diagnosed rejection. So patients that apparently, obviously had a rejection. So that's they lumped in 3 in the group 2, and I think that's fair. They all have ejection fraction. Have a rejection as much as we can tell. So all in all, they had 169 scans. 180 of them were matched with biopsy in 34 transplant patients and in 51 control subjects. So overall, the patient characteristics were, there is nothing very remarkable here. We will not go through that in detail. Very few scans have had to be excluded. And when they looked at the biopsy, they found that of the 112 biopsies that had a simultaneous CMR, and of course one should focus on them, about half were okay. So that's group 0. About 30% had a mild rejection, were in group 1. And 15% had clinically significant rejection with requiring immunosuppression therapy. So that's was roughly the distribution among the participants. And of 34 patients, hold on. So those 34 with the rejection and mild or more significant, 7 had clinically mainly defined by clinical criteria, significant rejections. So they developed, then this group developed basically normal T1 values from their group. So one might argue that, but it's probably a good approach using the scanner you use for the patients also to use the same scanner, the same settings to establish your specific normal values. And so they used the grade 0 biopsies with a normal ejection fraction. Now, they compared these with the non-transplant healthy controls, and there was no significant difference. So if heart transplant patients were doing really well, they were not really much different from the healthy controls. There was also no correlation between the T1 and age, sex, and timing to transplantation or other parameters. So across the rejection groups, now that was the first interesting finding. Here, by the way, here you see the compared grade 0 heart transplant patient with healthy control. So there's really not much to tell. Although T1 values in the transplant patient seem to have a trend to lower values over time. So between group 0 and 1, there was actually no statistical significance. That is interesting. T1 values were, however, higher in the acute response, as you can see here. And the values were also higher in those who had a clinically diagnosed rejection. So then well, I'll skip that. Here is maybe one of the most important figures in this paper. So the three groups, as described before, those without that were not, as shown in the previous figure, were not really different from healthy controls. Without any rejection, they had a low value, whereas the mild had a non-significant, but one may argue there may be a trend here. But the group 2, so those with clinically or otherwise secured rejection, had clearly higher T1 values. So again, here are the different groups, and you can see that the lumped group without sorry, I have to look up what the M stands for. Just give me a second. That was in one of the earlier figures here. No, I can't find it. So it's the acute rejection that was high. The clinical rejection was high, but also lumped. It was higher. So when we then look at the correlation, and that is interesting, of the T1 values with other markers, there are some interesting findings here. So interestingly enough, the extracellular volume was not really related to the degree of fibrosis. There was a trend of T1 values with the degree of fibrosis. And then the logarithmic scales, when they used that, there was a correlation between the native T1 and the troponin, the native T1 and the BNP. So there was a correlation, but it was not, on first glance, it was not necessarily all that extremely clear. But I'll come back to that later. So here is the sensitivity and specificity and variability of T1 mapping to identify transplant rejection. And when they used a cutoff of 1,029 milliseconds, there's a 1.5 Tesla machine, they reached a sensitivity of 93%, a specificity of 79%, importantly, a negative predictive value of 99% with an area under the curve of 0.89. So at least these data suggest that this is an accurate test, that especially, so that T1 mapping is accurate, but especially has a high negative predictive value. This is actually what you want to have in these people. You don't necessarily need a high positive predictive value, but you need to have a test that correctly identifies every single person that is at risk for a rejection or is having a rejection in order to initiate further tests. That could be a biopsy, and then treatment. So that is, to me, the most important takeaway of this paper. So T1 mapping in this setting apparently can be used for monitoring patients with heart transplant and identifying using a cutoff that would have to be verified by independent studies, of course, could identify these patients with a very high negative predictive value. So the critique of that paper, I think it is well done. Of course, it is not entirely clear how T2 mapping would have performed here, because in previous papers they used T2 and quite successfully so. And there's actually, I think 3 or 4 weeks ago, Chicago published a paper on T2. And what I already announced is that in 2 weeks at the next CMR Journal Club, we will actually look at T2 more in depth, and we'll also present that paper from Chicago. So that is something I've been missing a little bit here, because the T2 is more specific for acute injury because of the sensitivity to edema, whereas T1, of course, could also and did here also reflect fibrosis. So it is less specific, but of course the best would be to use both. And that brings me to the second paper. And unfortunately, Valentina Puntman, as the corresponding author, wasn't able to make it to the journal club. So this one is called CMR, Imaging Biosignature of Cardiac Involvement Due to Cancer-Related Treatment by T1 and T2 Mapping. It was published in the International Journal of Cardiology. And it's also a multi-center work. So what they did, they had and the background of this paper is not so much the transplant, but acute injury inflicted by cardiotoxic therapy. And that has been long known, and there are several papers in cardio-oncology now using CMR tissue characterization. And what they did is they looked at T1, T2, plus other markers, and then also combined them. So a total of 115 patients from London and Frankfurt, and 57 controls. And then 25 were assessed at 2, 12, and 18 months after cardiotoxic therapy, whereas the others they were just had a basically cross-sectional snapshot at that time. So they all underwent a standardized CMR protocol. The longitudinal scans were only done with native T1 and T2 and volume, so basically function T1 and T2. They used a MOLY sequence, specific, it's investigator specific, they call it. So let's assume it's a MOLY. I don't know that FFM MOLY too well. For the T2, they had two sequences, one the GRACE that is more and more popular now, and the more classic T2 flash. Because so that is something, one would have to, you always have to consider that the techniques come with different normal values and different sensitivities to certain tissue criteria. But all in all, they did a good job in correcting for that. So the subject characteristics there's really nothing remarkable there. You can look through that, nothing that would be not expected. The patients with the therapy, they had larger end-diastolic volumes, had lower ejection fraction, they had a higher LV mass, at least the early after therapy. So something that you would expect, and it's a nice confirmation here. It's almost, the signals are almost too clear. But also the native T2 was increased. But let's now go into that in a little bit more detail. So a native T2 with both was increased, whereas the T2 flash seemed to have a little bit of better discriminatory value, at least if you believe in the p-values here. The T1 was also different, so as you would expect in acute injury. But then if they correlated the troponin levels with native T1 and T2, they were actually positively correlated, but they were not related with the BNP, which is a marker for heart failure, not necessarily specific to any acute response. So what else did they find in this what they call a biosignature? So biosignature here stands for the combination of certain markers. For signature, one could argue it would be great to have more markers than that to call it a signature, but certainly there's a certain pattern. They correlated it with the involvement with the presence of early or late involvement after treatment. And what they found is that an increased native T1 and T2 when used for the early involvement was a good marker, and for the late involvement it was a native T1, a normal T2, and an abnormal global longitudinal strain. So that is interesting. So what they did is basically for the early involvement, they used T1 and T2. And that's of course also what are now allowed markers to identify myocardial inflammation. So these are the updated Lake Lewis criteria that they are allowed to use native T1 plus native T2. because these are markers for acute myocardial injury. So that only makes sense here. Whereas for the late enhancement, T2 may not play a role. And we also know that in other acute disease, that once it becomes chronic, the T2 is not such a great marker anymore. T2 is really only good for the acute phase, which in inflammation or acute injury would not go beyond, say, 3 weeks or 4 weeks. So normal T2, a native T1 that is increased, that indicates any injury to the heart, also the more chronic ones, and a longitudinal strain, which is one of the recently upcoming markers for the overall status of the ventricle. It's a marker that is especially highly abnormal in restrictive cardiomyopathy or cardiomyopathies that come with an increased ventricular stiffness. The classic is amyloid disease, but also end-stage valvular disease. So whenever you have something going on in the heart for long, then the chances are good that the global longitudinal strain is altered. And that may be the best of the strain markers for this type of disease, whereas the circumferential strain is probably the better for identifying ischemia or inducible ischemia. So, but this is for another day. So when they analyzed all this, and this is a very exhausting table to look at, of course, but the bottom line is that when you did a multivariate analysis, actually there was a good negative and positive to predictive value of native T1. And in another model, it was native T1 plus native T2, but especially when you use T1 and T2, then you end up with these really good values for sensitivity, specificity, and accuracy, and also negative and positive predictive value. So that is basically like a different situation than the suspected inflammation. But think about it. Cardiotoxicity is probably nothing else than inflamed myocardium due to a toxic aggression coming from the outside. So that makes perfect sense. This is reflective of acute myocardial inflammation. And I think that's already the main paper. So there are a couple of other quite interesting aspects in the correlation between them. And here's the comparison of between controls and all patients, controls early or late treatment. But you see that native T1 is actually always on top of the others. So as in all papers that come out with a relatively new finding, we always have to be careful, because everybody finds initially good results, and different approach or slightly varying approach by other groups may not find the very same accuracy. So this will have to be verified. But to me, that's a very strong signal here. But aside from the T1 and T2 that are displayed here, to me, a major point is that although the discriminatory value here is good, the fact, and that we had the same discussion in the myocarditis consensus group, or in the myocardial inflammation consensus group, the fact that T1 is not only specific for acute, but also reflects chronic disease, make it only logical to add T2. And that's why I would like to applaud these authors. So the combination of T1 and T2 in the acute setting, and the combination of T1 and longitudinal strain. So looking at combinations instead of single markers, I think that's a very valuable approach. And to me, that paper therefore has definitely merits, and I hope it can be confirmed very soon. And that would be kind of a good approach to these patients. So that's what I had to say to these papers today. Any comments, questions, remarks? Just unmute yourself, or if you feel free, then to text me or text in the Zoom chat, then you can write your answer, your question there, and I will read it. So there's a question from Andrew Korstein from Montreal. he says,
I asked that on the first paper, sorry.
Here, it's claimed to be a native T1, but there's a GAD injection as well. Yes, it's true, but what I said was related to the native T1 and not so much they also injected, but the ECV values, and I think you referred to the other paper, were not that impressive, so that's why I didn't go into too much detail there. Any other questions, concerns? Just unmute yourself and speak up, or you text, write that into the chat box. So if that's not the case, then, or if you still want to think about it, I wanted to just put your attention to two other papers that I found interesting to look at. One is myocardial perfusion mapping by CMR to detect obstructive coronary artery disease. So that's an interesting read looking at quantitative perfusion in macro and microvascular disease. We had that topic recently, and here's a review I wanted you to look at by Jasmin D and others. But Tom Marwick he's a very well-known, mainly echocardiographer from Australia. And there's a beautiful review of the current status of artificial intelligence in cardiovascular imaging. So who's interested in AI in the imaging world, this is definitely something to look at. And then for the Journal Club in 2 weeks, I have these two papers I would like to present. One is this one on anthracycline-induced cardiotoxicity. So we take what we had today, but here they are looking at T2 and T1 and ECV, but definitely in a very, very strictly controlled environment, because they had pigs and they did a very tightly controlled study with a very precisely defined protocol and histology. So that is a beautiful study. And then I will also comment on an editorial there. And then along the same lines, and we'll have to switch briefly screens here. Okay, so I will have to show it to the next time, because there is another paper from Chicago also looking at T2 specifically, and James Carr was with him on the phone. Either he or Michael Markle will join for that. So topic in 2 weeks will be T2 mapping, basically taking like part 2 of this one here, in cardiotoxicity and heart transplants. So they're both, of course, distinct, but both very similar, because they both represent acute injury that is associated with inflammation. So with that said, unless there are any remarks or questions, I want to thank you for your attention. And next time I will start to collect feedback while we're in the Journal Club, because I would like to sometimes get feedback, and I know it's not easy to speak up here, but I will then ask for hands up or thumbs up or thumbs down on some questions. So just to get some input from the team here. With that, I want to wish you all